right, everybody. So today on the podcast, we have Dr. Brad Stanfield. How we doing, man?
Yeah, good. Thanks for having me on.
Yeah, absolutely. I don't know if how many people on the channel are going to be as familiar with you. You've got a pretty big audience on YouTube. And I was just saying, I had seen you more recently because we'd had Nick Verhoeven on the podcast a few times. And as I've discussed with Nick, I really enjoy talking with him because obviously he's a very intelligent individual. But it also, to me, at this point, I've been lifting for 20 plus years. I've been very much in like the health and fitness realm for a very long time. And obviously, we're going to talk about general fitness. We're going to talk about general health, but I also like the ability to kind of dive into some deeper topics there. And obviously, we all have our own biases, but when I see a channel, those first 5, 10 videos you come across, you're kind of judging like, does this person seem legit or not? Do I agree or disagree with a lot of what they say? And really, I don't know if I've come across too much that you put out that I disagreed with. Now, that doesn't necessarily mean that everything is right, but we seem to be very much on the same page. I'm very interested to kind of pick your brain on some of these other more nuanced topics for sure.
Yeah, absolutely. And yeah, Nick from the channel Physionic, he creates some really, really high quality content. So yeah, it's wonderful that people like him actually, his channel's exploded recently,
Yeah,
and it's
definitely.
wonderful to see that type of content really moving in the public sphere. Because I think for too long, a lot of people, yeah, we particularly doctors such as myself, we didn't we kind of neglected social media. When YouTube first came about, I think people who weren't exactly evidence based started to flood that sphere, and that was because there was people want to know what they should be doing for their health, and what the best evidence shows, and I think. I think overall doctors were a little bit slow on the uptake with this, and there were people, I think, who filled that void, who weren't producing possibly the best content that they could have.
Yeah,
And so again, it's wonderful that people like Nick have come about and their channels are just exploding.
for sure. So for people who are not familiar with you, can you just give a little bit of background as far as your medical training and what you do with YouTube and all that?
Yeah, so I'm a primary care physician. So I graduated medical school in 2015, and then you have to go through the stages of being a junior doctor at the hospital, and then you have to do more training to become a primary care physician. I completed my training last year. So yeah, so I've been a practicing doctor for all this time, but it takes that long to actually become a fully qualified
Right.
primary care physician. And for the past 5 to 6 years, I've also been producing YouTube content because I wanted to create a resource for people to see evidence-based, medicine and what they should be doing for their health. Because, I think a lot of people they extrapolate from, single cell research or mice research or mechanistic reasoning, and that doesn't actually match what the either the clinical guidelines show or what the human clinical research shows. So yeah, I just want to create a resource that people could see what the clinical research actually showed, and what doctors like myself, if we had time, infinite time with our patients, the type of thing that we should be doing for preventative care, because prevention's obviously much better than treatment.
Sure, sure. Yeah, and I'm glad you brought up how, a lot of social media was almost invaded initially with people who maybe, shouldn't have had such a big voice. And it is tough because I will say, like, I think there's plenty of flaws with traditional medicine in the sense that obviously the doctor incentives, and again, I don't know how it is in New Zealand, but certainly in America, the doctor incentives can be very different than the patient incentives. And the care isn't always ideal. And so people recognize that, but then they kind of go too far in the other direction and they say, oh, this is, these doctors don't know anything and we just want alternative medicine and all these, and there you don't look at the evidence. And I think you brought up like, these mechanistic reasons, and a lot of times studies will look at these surrogate markers, and people look at this one thing and they think that it leads to that, to that, to that, and a lot of improper conclusions are made. And I think that's probably, at least in my experience and opinion, one of the biggest flaws I see is this idea that just because this happened in a petri dish or a mouse or something like that, that's how it's going to be in humans. And I think you do a very good job with your videos of saying like, hey, when we actually look at the human data, that might not be the same picture.
Yeah, yeah, I appreciate it. And yeah, people go online because they want to, yeah, they do want those alternative messaging because yeah, primary care overall it is broken. There's not enough funding, there's not enough time with patients, and most of the time we are just putting band-aids on problems because that's all we've got time for in the limited 15-minute consultations that we've got. And, people recognize that, again, prevention is better than treatment. And a lot of the time when you go and see your GP or your primary care doctor, by the time that you're coming towards the end of your 15-minute consultation and you've fixed the laundry list of problems that you may have presented with, you don't have time for all of that good prevention stuff. And so it's really tricky to do. And again, that's why I wanted to democratize this research. And because the clinical guidelines, they've got wonderful prevention strategies. And it's just a shame that we don't, as a primary care community, necessarily have the time to deliver that good care to patients, because it is so critical, but it's missing from our care. And I think that's why longevity and all these longevity clinics and wellness clinics have cropped up to try and fill that void. And
Yeah.
unfortunately, again, I don't think that they do necessarily the best job, because a lot of the times they're encouraging people to have expensive scans or expensive blood tests that they don't actually need. But it sounds good to patients. If you just measure all of these things that your primary care doctor isn't, that's why we are better, because we are giving you a much more holistic view. The clinical guidelines, though, are written in a way to only measure things when it's actually going to make a difference to patient management or patient care. And that's why the list of blood tests or routine blood tests that I do for my patients, it's actually relatively small, but that's by design. Because again, we want to deliver really good care for as low cost as possible for people. And that's a worry that I've got at the moment with with these wellness clinics that are popping up everywhere at the moment.
Yeah, I have a buddy who apparently just spent about $20,000 in New York City, just like a full comprehensive full body MRI and all these different blood tests. And I mean, people who know the channel know I've got a lot of blood work over the years, but it doesn't really cost me anything. And I'm just a very curious individual, so I like to test things. I'll see if I take this supplement, does anything change? But I definitely tell people you do not need to do what I do in that sense. I'm just, again, I'm very curious about how things change. But yeah, I've seen that a lot where like some of these tests that people are doing, where again, there's no standardization with it. It's just kind of like, let's just test everything. And do we even necessarily, I mean, some of the tests that were done in this individual's case, I know like we don't even necessarily have like great reference ranges for some of these things. And they're just kind of testing and saying, well, we think this might be that, and you could take us up and do that. And they're, just kind of guessing at that point.
Yeah, and there's an engineering term that I think helps people understand this. The best part is no part. The best process is no process. So if we can cut down on unnecessary tests and still deliver really good patient care, it allows us to give that care for much cheaper and much quicker, because you're just cutting down on the bloat. So a classic one is vitamin D. So the Endocrine Society, they recently published their updated guidelines about vitamin D and what we should be doing in terms of supplementation, in terms of blood tests. And they recommend that we should not be routinely screening people with vitamin D blood tests. And people who are new to the space will think, well, that's wild. That just feeds into the narrative that clinical medicine just wants you to be sick to get you addicted to
Right,
these
right.
drugs forever. And that's absolutely not the case. What the guidelines are written because there's been a truckload of studies looking at what happens when we try and supplement and get people to a specific range, and what that will do for their long-term outcomes in terms of cancer, heart disease, their long-term lifespan. And what seems to happen is that if you supplement with, say, 800 international units, which is actually, in terms of the supplements that you can buy over the counter, it's actually a relatively small dose.
Yep.
That gives you all of the benefits of vitamin D, and therefore there's no actual need to measure your vitamin D levels, because so long as you're getting 800 international units, your vitamin D levels, yeah, you'll be getting all of the benefits from vitamin D supplementation. And that 800 international unit recommendation, that's assuming that you get no sunlight exposure whatsoever. So yeah, that's the reason why there's not these massive blood test forms that we do for patients in the clinic, because again, we just want to focus on the ones that will truly make a difference for patients' health.
In that example, are they recommending everybody then take 800 because it's such a low dose, but it'll still cover it? Because if you're saying they don't test it for everybody or even anybody, I guess I'm wondering who are they recommending that 800 for?
So They recommend it for they recommend supplementation for high risk individuals. So, for
Just
example,
high risk. Okay.
if you're in a rest home, yeah, and you're not going to see much sunlight, that's a reason to do it. If you're mainly working indoors, if you supplement with 800 international units, that will mean that your level's absolutely fine. For people who were worried about their bone strength, so say for example, postmenopausal women, um, that's a reasonable option to supplement with vitamin D. Um, Now, taking their guidelines, most of us aren't seeing enough sunlight, and therefore it's reasonable to supplement. So I personally take a vitamin D supplement at 1,000 international units, and I know that is going to make sure that I'm getting all of the benefits from vitamin D without some of the harms. Because when they updated their guidelines, they were looking at what happens if you start supplementing with higher doses. So 2,000, 3,000, even up to 10,000, and interestingly, there seems to be, and we don't fully understand why, but it seems that if you start supplementing with higher doses, people's muscles actually seem to get weaker. And we could see that because people were falling more often. So these were studies done in older adults. And there was a concern as well about bone strength. So yeah, we just need to be careful that if we start supplementing with higher doses and we think that, more is better, that isn't always the case. And again, we do have evidence now that those higher doses of vitamin D are actually causing people harm. So that's why the guidelines recommend 800 international units because it gives you all of the benefits and minimizes that side effect profile.
I know it's harder to run these type of studies, but I would love to see that data not related to dose, but related to blood levels. Because for a while it was, everybody was recommending vitamin D. And I have seen in recent years some of this pullback from that, saying, hey, you know what, it's maybe not necessary for most people. But generally, if we're looking like the standard units, people say, okay, under 30 is maybe problematic, under 20 is like pretty deficient. So I'll tell you just personally, I was at 17 on the blood test, so I started supplementing. Now, I personally take about 4 to 5,000 IU's per day, which is obviously well above what you recommend. That again, just from the blood work,
So so
gets
so just to clarify, it's not what I recommend, it's what the Endocrine
yeah,
Society
yeah, yeah, sorry.
recommends. Yeah.
And so that gets me into like the mid 40s. So it's not, because I have seen data suggesting that when you're at like 80 to 100 as far as like on the blood test, then you start getting problematic. So that's why it would be interesting, and maybe this answer. Are we just focusing on dose or are we focusing on result? Because I would think that mid 40s is kind of like a pretty safe level. But what are your thoughts?
So that's what the Endocrine Society in their updated guidelines also looked at is, these blood levels. What do they actually mean? Why do we have these ranges set where they are? And there's actually no good reason for it. It's a bit like trying to bake a cake when you don't know the degree that you should be baking your cake at. We don't know what the best level is, and the reason for that is so long as you're not, super duper deficient, like say below 10, um, there doesn't seem to be much difference in health between, going from say above 10 to above 50. So this blood test that we're doing, if we don't know the ranges that we should be trying to target, what, that gives even more reason as to not do the test in the first place. And
Right.
and further research needs to be done. But again, if it's a bit like magnesium. If people just reach the recommended daily intake, so in this case, again, 800 international units, you're getting all of the benefits that you need. And it means that you don't have to spend your money on vitamin D tests and trying to optimize that because actually that's not going to change, your cancer rates, your strength, your cardiovascular disease rates. There's no advantage
Yeah.
for supplementing with more than that outside of specific populations. For example, um, pregnant women, that there is some evidence to suggest that maybe you do want higher doses of vitamin D. And again, that's reflected in the Endocrine Society guidelines. But coming back to this, primary care, it seems quite simple because there's only a few things that we do. And the reason why we do that is those are the things that actually make a difference for people's health.
Right.
And we try and be laser focused, a bit like using a scalpel to try and focus on those things so that we can actually shift the needle for patients' health.
Sure, and it makes sense. And not only is there the cost, like you said, there are health risks to certain supplements. I mean, one, you have to even trust that the supplement is what it says it is, which, hopefully you're using a reputable brand, but obviously like that's a whole separate topic of, can you trust necessarily the supplement industry? But then yeah, like it's something like I'm not actually I take a number of supplements, but I'm not huge on supplements. There's like a few key ones that I do take and recommend. But yeah, I agree. And I just literally watched the video you put out. I think it was today or in the last day on some of these supplements other people take. So that maybe is a good topic to kind of get into, where some of these things that we assume are just generally healthy. You mentioned calcium and iron and whatnot. That one, high levels might not be beneficial, but then two, particularly in a supplemental form, which we've seen with like, even going way back, vitamin E was another example, right? So do you want to touch on that at all? Like just like the idea that just because
Yeah.
it's good, that it's not necessarily good on a supplement.
Yeah, a lot of this is to do with the dose. So say for example with vitamin E, there's some evidence to suggest, and th these are the evidence that I'm referring to here are meta-analyses. So where they pull together, different randomized clinical trials, cohort studies, etc. It seems that when people start taking vitamin E supplements, that's correlated with higher mortality rates, as in you're going to die earlier. And it's the same with vitamin A. Um, and the potential reason for it is that both vitamin A and vitamin E are antioxidants. And if we start to boost our levels of these, you potentially can disrupt the balance between oxidants and antioxidants in your body. That's a potential mechanism for it. And also, from a good diet, you're getting all of the vitamin A and vitamin E that you need.
Mhm.
So I personally don't take vitamin A or vitamin E supplements because of the data that is a bit concerning. It's the same also, say, with vitamin E and prostate cancer. There is some evidence to suggest that taking vitamin E supplements will increase your prostate cancer risks. So, taking even vitamins, you have to be careful that the dose is so critical. And if you're getting enough from your diet, you don't need to be supplementing with more because more is not always better. And another classic one is iron. So, yeah, there is a patient population where potentially you do want to supplement with iron, and that's generally premenopausal women. So in those in that population, you potentially do want to start supplementing with iron. But for the vast majority of people, we're getting all of the iron that we need from our diet. And unless you've got specific absorption issues like inflammatory bowel
Bowel
disease, for example,
disease.
like Crohn's disease,
Yeah.
you might not be absorbing the iron that you need. And again, in that patient population, yes, you might want to be supplementing with iron, but for the vast majority of people, you don't need to be supplementing with iron because again, you're getting it all from your diet. And so I think, yeah, we just need to take a bit more of a dare I say, clinical approach to supplementation, where you're actually being a bit more targeted in terms of what you're putting in your body. Because there are some supplements that do have really good evidence, like creatine supplements, for example. That's a wonderful supplement for most people to be taking. And I think if we shift people's view to supplements like that, where if you do want to spend your money on supplements, go for things like creatine,
Right.
you can actually, again, shift the needle a bit for people.
Yep. Yeah, for sure, for sure. And obviously when I talk about like fitness and whatnot, that's a classic industry where a lot of people who are new to it are immediately looking for the supplement, which you look like a pretty fit guy, so I'm sure you've had plenty of experience there. But obviously, the vast majority of the results come from diet and lifting and whatnot. I mean, honestly, I even would say that supplements make a greater difference in health potentially than let's say like strength and performance. I mean, even creatine, which is the most studied supplement we have in that realm, I would say that it's likely it gives you this kind of bump and it doesn't necessarily change the curve or the rate of growth over time. Meaning, like in my like thought is if you had two twins, one took creatine, 10 years, the other one took no creatine for 10 years, they lifted, everything else was identical. It's not like the one with creatine would just continually better, better, and better and better. It might be like a 2 pound lean body mass boost or something like that. I don't, so I know you recommend it as well. I don't know if you have different thoughts on creatine specifically, but I think in the lifting realm, they can be very overhyped, obviously.
Yeah, they're definitely the cherry on top. But it would be interesting to have that, such a study like you've just mentioned. I think with creatine though, there are a couple of other benefits in terms of cognitive performance.
Sure.
But in terms of muscles, it does seem there is some evidence to suggest that if you do take creatine supplements, you're less likely to get an injury. Maybe if over the long term, if people are getting less injured because they're taking creatine supplements,
Sure.
maybe that way you can potentially see a benefit. But yeah, I agree that supplements, they're definitely the cherry on top. The meat of health is diet, exercise, and sleep.
So one thing I want to talk about that's not really a supplement, just a medication, I would say kind of popularized more with Peter Attia talking about it. This rapamycin trial that you're doing. I don't know how much you can or cannot discuss details. Can you just kind of go into that, like what you're studying and what piqued your interest with it?
Yeah, absolutely. So when I first started looking at aging and what research was out there in terms of being able to slow down or even reverse aging, the golden egg, if you like, from that area of research seems to be rapamycin, because over and over again, when you test it in worms, mice, flies, it extends lifespan. So one of the best preclinical models that we've got is the interventions testing program. This is a program that it's in mice, but it runs the same experiment in three separate labs at the same time. And that way you can see whether the results are true and reproducible. And whenever they test rapamycin, it extends both male and female lifespan by over 20%. So it's significant. So then the question is, can we translate that into humans? Because that's the next big hurdle. Because most of the time when you see a result in mice, it doesn't translate over into humans. But rapamycin has got a bit of a dirty name in clinical medicine. So it's used as an immunosuppressant. So, for example, if you needed to have a kidney transplant, one of the drugs that you'll be on to prevent your immune system from attacking that donated organ is rapamycin. So, people are naturally concerned that if you're giving an immunosuppressant to an otherwise healthy patient population, are you going to be causing them to have more infections and more cancer and whatnot? So, the research on this has been quite slow. Um, but again, it seems that the dose is so critical. So, um, if we're trying to get lifespan benefits from rapamycin, we probably need to wind back the dose significantly. And most people who are taking rapamycin outside of the clinical guidelines, and they manage to find a doctor who's willing to prescribe it, they'll usually take rapamycin once a week. So that's the dose that we chose for my study, because one of the things that I'm really curious about is muscle strength as we get older. And as I'm sure you'll be aware, if you exercise, you activate an enzyme called mTOR, and mTOR it stimulates muscle protein synthesis or muscle protein building. And it seems that as we get older, our bodies recognize that the muscles are getting weaker, and so they start to overactivate mTOR. It's almost like they're trying to rebuild their strength. The trouble is, if you're overactivating mTOR, you're not allowing another process to happen, which is called autophagy, so the cell clearance process. So you can think of your cells as, trying to desperately, build up these new proteins, and they're never flushing them away. It's a bit like a hoarder's house. You're gathering all of the stuff, but you're never flushing it out. And so the concept that I wanted to explore in my clinical trial was if you use rapamycin once a week, where you allow autophagy to happen because you switch mTOR off and you flush out all of these old damaged components, and then exercise, you can rebuild and activate mTOR, you can rebuild new proteins. Would that improve muscle performance or not for older adults? And we've completed the study. We're going through the analysis at the moment, and I do know the top line numbers. And until it's peer reviewed, I don't want to get too ahead of myself. But yeah,
Sure.
it's going to be quite the finding when we publish these results, and I think it's going to have a lot of implications for people like Peter Attia who are taking rapamycin off label. And on that point, I I, I personally don't take rapamycin. I've never prescribed rapamycin, and I don't recommend that anyone takes rapamycin outside of the FDA approved indications in clinical trials like my one, because we don't yet know the benefit versus risk profile yet. Even in my trial, it's only of 40 participants. So it will give us a signal as to if we're moving in the right direction or not. But again, we need far more research, in my view, before it's recommended to people, or people take it. But yeah, the top line result, it's going to create quite a stir when it's
Interesting.
when it's published.
And just to clarify, your hypothesis was that the group taking rapamycin would have a greater adaptation to resistance training?
Yeah,
And
yeah,
and why would
that's
that be
right.
the case if it's inhibiting mTOR?
So this population is of older adults. So at a baseline, they are overactivating mTOR. So
Okay.
that they're never allowing, or that yeah, their rate of autophagy is wound back. So if we try and rebalance mTOR by again only taking rapamycin once a week, hopefully we would see improvements in muscle performance again, because we're instead of these people overactivating mTOR, we can get them down to a level, say, when they were 20 or 30.
Okay. So, and this just might be my ignorance on the topic. Is that something? Because, generally, again, in the fitness world, it's always like this stimulates mTOR, leucine stimulates
Yeah,
mTOR and all of that. And so, is the theory there that it's more of a balance of mTOR that is ideal, essentially?
yeah,
Okay.
yeah, that's right.
And is
That's right.
that is that something that we're seeing elsewhere that indicates that? There are other instances where we see clearly, due to higher levels of mTOR activation, there are, let's say, worse adaptations to resistance training or anything else? Or is that just your theory that too high of mTOR is a problem?
So we see it in mice that
Okay.
when mTOR is purposely switched on, it actually causes weakening of the muscles.
Okay.
So in mice, when the baseline mTOR activation is quite high, overall, instead of continuing to build muscles, these mice actually get weaker compared to mice that don't have their mTOR always switched on.
Okay. And again, obviously, a study only shows what a study is particularly testing, but could a next study, like, let's say this shows positive results, it seems like maybe it's going to lead to what you think is going to happen. Could the theory then be, okay, if we want this balance of mTOR and we're thinking or extrapolating to longevity, perhaps something like a rapamycin is not beneficial to, let's say, somebody who's 30, but could be for somebody who is 65. Maybe there's like a time in their life when it's more helpful for longevity.
Yeah, potentially. But again, all of this is speculation because we don't have the human research yet. But yeah, if I had to guess, I'd say that people would probably only start to see benefits from rapamycin, if there are any benefits in otherwise healthy individuals, from about the age of sort of 40 or 45. But again, that's pure speculation.
Sure.
We don't have the human research yet.
Yeah, no, I'm just thinking because, like, there's obviously other mechanisms that lead to health issues, like, obviously, ApoB concentrations that we look at more like area under the curve over one's lifetime, where you could argue, like, hey, in theory, somebody who is taking rosuvastatin from 20 to the rest of their life could have a greater benefit than 60 to the rest of their life, right? So kind of the opposite idea there. So yeah, that is super interesting.
Yeah, yeah. So it's I wanted to get involved in this area of research because it's so under-researched, even though it's so exciting from the preclinical world.
Mhm.
And it's not only because rapamycin's got a dirty name in clinical medicine because it's used as an immunosuppressant, but there's also no money to be made. So
Yeah,
people have known about rapamycin since the 1960s. You can't patent it,
right.
um, and generics are available. So yeah, it took me about 2.5 years to get funding for this research because clinical studies to get ethics approval to make sure that they're properly done, that they're audited, that they are, yeah, it so this 40-person study that I did, it cost roughly about $750,000 to do. So
Wow.
it's significant.
And
It is
how's that
significant to
funded?
run clinical studies.
You just
It was crowdsourced. So I was talking about, yeah, rapamycin and exercise in this clinical trial for about 2.5 years on my YouTube channel, and slowly we got the funds together from people that wanted to actually donate
Wow,
to this research.
that's awesome, man. Now, I think I saw something about you getting a PhD. Is this part of getting a PhD for you then? Is that part of this process or
So yeah, I've been accepted by the University of Auckland to do my PhD.
okay.
But that this existing study doesn't have anything to do with that PhD. So
Okay.
I do want to do my PhD in rapamycin, and because there are other clinical trials that I do want to start running for rapamycin, and that's what my PhD will be.
Wow.
So this was just an interest project that again because I think people need to research it 'cause it's just so under researched.
Yeah. So you're a physician, you got a big YouTube channel, you got 3 kids, but why not throw on a PhD on top of it, right?
Yeah, yeah, well, figured, yeah, not busy enough, right?
Right. That's awesome, man. That's awesome. Cool. So One thing I would love to talk about is the research that's being done. I guess was just kind of released the lean mass hyperresponder paper. And this is interesting to me because I mean, I've obviously heard the term talked about a little bit with Nick Norwitz, or not Nick Norwitz, excuse me, Nick Verhoeven. I did want to have Nick Norwitz on the podcast almost a year ago. We were going to discuss this generally, had set it up, and last minute he had kind of flaked on it, so we have not actually had a time to actually sit down and like podcast about it. But my understanding is the social media presentation of it has been very different than the results themselves. So maybe for people who are listening who don't know what we're talking about, do you want to just define what a lean mass hyperresponder is and kind of what was studied?
Yeah, so there's debate on social media, and somewhat in the scientific space about, what happens if people are lean, but they're on a very, very low carbohydrate diet. And in some people who are lean and on a very, very low carbohydrate diet, their LDL cholesterol levels just skyrocket, shoot through the roof. But their HDL cholesterol goes up, and their triglycerides go down. And there's this term that people like Nick Norwitz have come up with called the lipid energy model. And so through their hypothesis, they were expecting to see that people who were lean and met their triad of a lean mass hyperresponder, again, that's the high LDL cholesterol, high HDL cholesterol, but low triglycerides, that there wouldn't be any further or there wouldn't be any increased risk of cardiovascular disease compared to someone who wasn't a lean mass hyperresponder. So maybe these people were just lean but didn't have sky high LDL cholesterol. And so they set up a clinical trial to look at this. So they got, I think, 100 people who met their criteria of being a lean mass hyperresponder. So again, these people had very, very high LDL cholesterol levels, and they followed them up for 1 year, and they did scans of their blood vessels around the heart. So at baseline, so before the study began, and 1 year later. And this is where things start to break down a bit because they named their paper "Plaque begets plaque, ApoB does not," or something like that. They were basically trying to say that if people already had plaque in their blood vessels, but before the study began, those people would develop more plaque over that 1 year period if they were a lean mass hyperresponder. But otherwise, there was no correlation between ApoB and LDL cholesterol levels in terms of the rate of plaque progression. Um, but that's not at all what the study showed. Um, what the study showed quite alarmingly was that these people, and you can see this on the graph, which again we'll come to because there was a problem there. These people were gaining a lot of plaque in their blood vessels, and obviously that's not great because that would increase their risk of heart disease. Um, and but how that was reported was quite alarming because all they reported was a graph, and that was their primary outcome. That was the one thing that they were going to hang their hats on to either prove or disprove their hypothesis. And they buried it in a graph. They didn't actually give you the raw numbers. And so with overwhelming pressure on social media, they finally gave their raw numbers about what was happening in terms of plaque. And these people were gaining plaque at a far higher rate compared to other high risk people. So if you were, obese and had type 2 diabetes, you would be getting plaque in your blood vessels. But these lean mass hyperresponders were gaining plaque at an even higher rate compared to, people with type 2 diabetes. So it's alarming.
Yeah.
And that is what we would expect based on the lipid hypothesis that if your LDL cholesterol or ApoB levels are high, you're at a higher risk of developing plaque in your blood vessels and heart disease, and that's exactly what we saw in this study. But unfortunately, the social media communication, because I think these authors don't want to let go of their hypothesis. Basically, they created data that disproves their hypothesis. Um, yeah, that they haven't. That I just don't think that they want to let that hypothesis go. And that's the sad thing because if I think they had a reasonable hypothesis that they wanted to test,
Yeah.
and I think they should have celebrated that actually that their hypothesis is wrong, and that yes, even for people who are lean, who are on very low carbohydrate diets, if your LDL cholesterol levels are high, we do need to address it. We do need to bring it down. That's what our data shows. But unfortunately, that's not the approach that they've taken,
Yeah.
and rightfully so. They've been called out significantly by the scientific community because of this.
Yep. Yeah. So I just want to pull up some data I had here. So I am a lean mass hyperresponder when I do very low carbohydrate diets. So I've done ketogenic diets in the past. I did a 1 month experiment on a carnivore diet just to kind of test it out for the sake of it. So I'll just read that blood work here. So 3 weeks into the carnivore diet, my total cholesterol was 449. My HDL was 92. My LDL was 346, triglycerides 92. And on a ketogenic diet, it's not that extreme, but you'll still see cholesterol in the like 300s and LDLs in like the 200s. So even though I actually felt great doing that, I do not at all buy into the idea that like, oh, it's all about how you feel. I think I mean, there's literally a million examples of where that does not apply. So I was not comfortable doing that. And there's other reasons I wouldn't want to do it. But that alone for me, I do believe that there is sufficient evidence to suggest that high levels of LDL and ApoB specifically do, increase one's risk of cardiovascular disease. And so it was definitely personally interesting to me as somebody who had such a strong response in that regard. And again, did feel pretty good doing it. Not to mention, if we're talking carnivore specifically, I do think there's issues with having no fiber and plenty of other potential issues with a carnivore diet long term. But yeah, the paper is very interesting. I still would like to talk to, I think it's Nick Norwitz and Dave. I'm blanking on his last name. Um,
Dave Feldman.
Feldman, right, right. Just to kind of have a discussion on it. I don't know who they have and haven't had a discussion with as far as like outside of their own kind of circle there. But yeah, it's something that I'm glad that people like you and Nick Verhoeven and Peter Thiel like are definitely popularizing more so the idea that there's issues with these high levels long term. But yeah, it's interesting to see that.
Yeah. And just on the point of the carnivore diet, so there are people, say for example, who have got undiagnosed irritable bowel syndrome. And for people that have got irritable bowel syndrome, we generally recommend a low FODMAP diet. And basically that just is a diet that tries to reduce the amount of gas and things that your digestive system creates during the digestive process. So the carnivore diet meets that. And so some people with undiagnosed irritable bowel syndrome or inflammatory bowel disease, some of them will do really, really well on the carnivore diet and they'll feel amazing and they can get off their medications and it's wonderful. And so I don't think that we should discount that there are some people where the carnivore diet or a very low carbohydrate diet does work really, really well for them. And we need to try and support those people with that diet because it's working well. But again, we can't then say, okay, even though it's working well and we've got you off all of these other medications, now we can just ignore your LDL cholesterol. That's not at all what we should be doing. And again, this lean mass hyperresponder data shows that if you're even if you're feeling great, if you've got a high LDL cholesterol level or ApoB level, you will be developing plaque in your blood vessels, and we do need to address that.
Totally agree there. Did I see in a video that you personally take rosuvastatin? Is that something you mentioned?
Yeah, I've actually recently switched
Okay.
to pravastatin, 20 milligrams, and we can go into that if you like. But
Yeah.
yeah, I've taken I took rosuvastatin for 2 years, 3 years.
Okay.
So yeah, so I I get confused between US units and the units that we use here in New Zealand. But I think in terms of US units, my LDL cholesterol would have been around sort of 80 milligrams per deciliter. So pretty good.
Yeah.
Um, but there was a study done called the PESA study, PESA, and this was an observational study that was looking at that measured blood vessel health and the plaque that was in those blood vessels. And the crucial thing about the study was that it looked at people who were lean, who didn't have type 2 diabetes, they were insulin sensitive, blood pressure was perfect, they had no other risk factors for heart disease aside from LDL cholesterol levels. And you could see quite clearly on the graph that so just LDL cholesterol by itself, as that goes up, more and more plaque develops in your blood vessels. And The cutoff in that study was around 60 milligrams per deciliter. Below that, there was no plaque seen in blood vessels.
Mhm.
So, based on that research, I made the decision that I wanted to be quite aggressive with my LDL cholesterol targets and get myself below 60 milligrams per deciliter. And I was already having, a good diet with, low saturated fat, lots of fiber. There was nothing else lifestyle-wise that I could do to bring my LDL cholesterol down further. So that's when I started taking rosuvastatin 5 milligrams. And just for people who might be new to statins, basically they work on your liver and tell your liver to not produce as much cholesterol. That's roughly how they work. So yeah, and that brought my level down to I think it was about 55
Okay.
milligrams per deciliter, and I was happy there. But then I wanted to start taking another medication because uh, high blood pressure runs in my family. So again, even though we're lean, we have a low salt diet, again, lots of fiber, our blood pressure is it runs higher than what it should. So there was a combination of blood pressure medications that I actually needed to go on, and one of the side effects of one of these medications that I was going on was that it slightly elevates your LDL cholesterol.
Hmm.
So that pushed me to about 65 milligrams per deciliter.
One of the
So
blood pressure
so
medications
to
did that?
combat that, sorry,
One of the blood pressure medications you were taking increases
yeah,
LDL? What medication, if you don't mind
yeah.
me asking?
So it's not typically used as a blood pressure medication. Again, this is a bit nuanced as to why I wanted to go for this drug, but I went for empagliflozin, which or Giardians
Okay.
is the brand name. This is an SGLT2 inhibitor. That's the
Yeah,
classic
yeah.
medication. And it's a diuretic. And through its diuretic effect, that's possibly how it slightly increases the concentration of LDL cholesterol.
Hmm. Okay.
Um, so yeah, so that pushed me slightly above the 60 milligrams per deciliter that I was targeting. So then I added another medication called ezetimibe. Ezetimibe works by telling your gut to not absorb as much cholesterol because I didn't want to increase the statin dose again for reasons that we can go into if you want. And that got my LDL cholesterol to about 35 milligrams per deciliter. So I was possibly
Wow.
overdoing it slightly.
Did
There's
ezetimibe
no
drop
harm
it
in
that
doing
much
that, but
more? Interesting.
yeah. But there's no real harm in doing that. But that I wanted to use as low a dose as I could in terms of statins. And pravastatin, that's a short-acting statin, and it's a bit weaker compared to rosuvastatin. So pravastatin, it only works at night because that's when your liver produces most of its cholesterol. So yeah, so I switched to pravastatin 20 milligrams, which again is quite a low dose, and not particularly potent. And I am going to be on that for 2 or 3 months, and then I'll repeat a blood test, and hopefully the blood test will be around sort of 50 milligrams per deciliter. But that's a rough story in terms
Yeah,
of
yeah. And
the
so you're
medications that
keeping
I
the
take.
ezetimibe with the pravastatin.
Correct.
And
Yeah,
what's the ezetimibe dose?
10 milligrams.
10. Okay, gotcha. Yeah, so I a little bit different story, but for years my cholesterol, my if we're just focused on LDL, was like around 100, and for the longest time before it's kind of this like prevention stuff came out, or the greater emphasis on prevention, it was the markers would tell you, okay, you went under 100 roughly. And so I was like, okay, it was fine. And over the years, it kind of was like creeping up a little bit. And my diet was always good, but I did have saturated fat for sure. Love cheese. And so, I would get up to like 120s to 130. And then most recently, now over a year ago, it was like 132. And I even had like 140 at one point. I was like, okay, like this is now, I'm getting close to, like early 30s. And I'm like, okay, this is something that I think I want to address. So I did a saturated fat experiment where I went 2 months of basically no, like when I say no saturated fat, I mean under 15 grams a day, but many days were under 10 grams a day. And it was a pretty dramatic drop from about 142 at its peak to 67. And I was like, wow, that's
Nice.
amazing. But you can imagine it's a very limiting diet. And I was pretty amazed to see that with even just one saturated fat, just like pizza and burgers, whatever, one saturated fat meal per week got me back up to about 90. So a pretty big jump for just once a week. And like, I'm a very strict individual, but if you're telling me I can just literally never enjoy some of my favorite food ever again, like that's a
Yeah.
tough sell. Especially when the safety data on statins and whatnot is pretty great. So, I won't go into all because over a whole year I did these various experiments. But what I found was that even having 3 or 4 of these cheats per week just a 2.5 milligram of rosuvastatin dose per day got my LDL to about 70. And I said, okay, well, what about if I combine it? So I'll allow 1 or 2 cheats per week with the 2.5 milligrams of rosuvastatin. That has me at 60. And that to me, I'm pretty happy with that. So
Yeah,
I'm using half of the lowest prescribed dose of rosuvastatin. And, it's a very nice balance where I eat really great tasting food, but if I go out and I have something, I'm not too worried about it. I'm currently experimenting coming off the statin for two reasons. One, I wanted to see if off the statin there was any sort of cognitive difference, if I had any sort of like brain fog changes or anything. I can't say that I've noticed any difference. I think it was the same on and off. Obviously, a lot of people have a placebo or nocebo effect when they go on some of these things, especially if you read all the comments online about the horrors of statins and whatnot. And the second, and this is a kind of totally different topic, but I had a CGM for people listening, a continuous glucose monitor, and I was kind of surprised by some of the spikes I was seeing. And, for people who don't know, there is a small risk of, insulin issues with statins. And I was very surprised to see that my fasting glucose levels were quite high. And this again could turn into a whole another topic. But what I noticed is I was having many, like immediately when I was waking up, because I bought, one for like a finger prick and like above 100 for fasting glucose. And yet I would go to LabCorp and it was always like in the 80s. And the reason I believe is the dawn phenomenon. So for people who don't know, as you're waking up, you get this cortisol spike. And as far as I can tell, that's kind of what I'm seeing. So I don't know if you have thoughts on that. If like, hey, if somebody has levels that are 100 to 110 glucose in the morning, but like, 5 a.m., but by the time I would get my normal blood work, which would be like 7 or 8, it was fine. HbA1c is about 5.3. That didn't really change on or off the statin. Seemed to have a normal response when I eat something, it'll go down relatively quickly. But I just, that's like something I was a little worried about. So I wanted to see. Now I'm off the statin. The fasting glucose levels are no better, which you could say is a good or bad thing depending on how you're looking at it. I almost view it as a good thing because now I can more comfortably go back on the statin. But it was kind of like a new phenomenon to me because I never had so consistently tested glucose at 5 a.m. So anyway, that was a very long ramble. So, your thoughts?
yeah. There is good evidence now showing that for people with pre-diabetes, if they go on a statin, they're more likely to develop full-blown type 2 diabetes. That increased risk is very small, but that risk is there. But in saying that, even for pre-diabetics or for type 2 diabetics, the guidelines still recommend that we should be on statin therapy. And the reason for that is if you're pre-diabetic or type 2 diabetic, you're more likely to develop plaque in your blood vessels just because they're a bit more inflamed. And we do want to be doing everything that we can to lower our LDL cholesterol levels. And when you um, when you take a statin, you are type 2 diabetic. Yes, your sugar levels might be slightly higher than if you were off the statin, but your overall risk of cardiovascular disease is lower. And I think some people get a bit confused in terms of what we're actually trying to target with medications and with lifestyle changes. The overall thing that we're trying to do is prevent plaque from developing in your blood vessels and prevent heart disease. Though primarily prevent heart disease. That's the big thing that we're after. So again, even for so I just want to put that concern to rest is that even if for people who are pre-diabetic or are type 2 diabetic, the guidelines still recommend statin therapy. But say for you and I who aren't pre-diabetic, um, yeah, this is the reason why I switched to pravastatin because it's a weaker statin and the increased risk of problems with insulin sensitivity are actually lowest with pravastatin because it's one of the weakest statins and it's got such a short half-life. So since I was taking rosuvastatin at night anyway, I figured, well, hey, I may as well just switch to pravastatin 20 milligrams, which it's not going to lower my LDL cholesterol as much, but again, my levels are absolutely fine at the moment, and I've got room to slightly increase them. So it's probably me just over optimizing. But I figured, hey, well, I may as well try and do everything that I can to remain as insulin sensitive as possible. And so switching from rosuvastatin 5 milligrams to pravastatin 20 milligrams is probably a good option.
Cool. So, you touched on the blood pressure a little bit. And one thing that I really haven't seen convincing data to me is on sodium intake for people who have like perfect blood pressure, in that I'm fully on board with like, we obviously don't want high blood pressure. And, there's plenty of evidence to suggest that, hey, even like what we used to say was okay blood pressure, maybe actually a little bit lower is preferable. But I take somebody like myself, and of course, now look, I'm biased. I love salt. I like to salt my food. But I mean, I literally like every time I stand up, I get orthostatic hypotension. So for people who don't know what that is, I mean, I almost lose my vision. And I've once or twice actually like passed out because my blood pressure is quite low. My normal blood pressure is like 95 over 65. I I haven't seen anything that sodium itself is inherently problematic. It seems to be that sodium ability to raise blood pressure is the problem. Have you seen any data to suggest that sodium itself, in the absence of hypertension, is a problem?
The one study that I reference on my channel, it was a meta-analysis of 84 different clinical trials, and it shows quite clearly that as sodium intake increases, blood pressure increases. But again, there's nuance to that. Like, say someone like yourself who's got a baseline of very low blood pressure, and if anything, it's potentially too low, and that's why you feel unwell when you stand up, and you've even fainted. We do need to be very careful in terms of what we recommend for you with your sodium levels. So I think at a population level, yes, the evidence is there that we do want to be reducing our sodium intake, but we do have to individualize that guideline, because again, telling you to reduce your sodium intake would probably actually do you harm. So and that's where the so-called art of medicine comes in. That you do need to treat the person in front of you. You need to listen to them, and again, individualize the treatment plan for that person. So for you, I wouldn't recommend reducing your sodium intake. But you're quite a different case compared to
Sure.
the vast majority of people.
Good. I will continue to load up on my sodium then. Cool, man. So the last topic that I wanted to touch on is, and this is obviously going to be largely speculative, is just where medicine is going, especially in terms of technology and AI. Obviously, AI is a huge buzzword at this point, but what I find, what has excited me about AI, and I've gone from, not, I mean, obviously AI is kind of like a general term, and obviously now it's something that's like marketed and like, oh, we have AI for this and that. But let's just say things like ChatGPT and Grok and whatnot. One of the things that I have liked the most about them is the ability to look at a problem, and whether it's like a certain calculation you're trying to run that's complex, or it's something, hey, like, can we use it as like a medical hub, and like literally just say, hey, I have this going on, I have this going on. I just saw some news story. It was like, woman, ChatGPT helped a woman realize she had thyroid cancer after doctors dismissed her, et cetera. And you could go into that. But I think from a medical standpoint, one of the reasons it's fascinating is it's very common. You go to a doctor, you might have a series of questions. They have 15 minutes for you. And they don't, and look, I mean, I treat over 2,000 patients. Like, it's hard to individualize everything and talk to every patient about every little thing. If you, let's say, use ChatGPT and you're like, this is now my medical hub. Here's everything I have going on. Here's my blood work. Here's this. There's no rush. You can ask a million questions, and obviously there's flaws and things you have to watch out for. But I think it's awesome that you can just solve these bigger and bigger problems. And you have like the fantasy of everything's just going to be solved and everything. And so, we don't know what's going to happen 100 years from now, of course. But what do you think of the next 5, 10 years, like real applications for what AI is going to bring? Do you think it's going to be almost unrecognizable, or is it just going to be like, hey, it's going to help us just be a little more efficient?
Yeah, I think from the bits that I've read about in terms of drug development and understanding how proteins fold and creating new treatments, that is really, really interesting. And I think that's significantly speeding up drug discovery and whatnot. So that's really cool. The use case that you just said where if a patient has got all of their list of symptoms, their blood work, and they're potentially that they maybe don't have access to a doctor, or as you said, maybe that doctor's a bit too busy to fully dive into their medical record and figure out what's going on, or that doctor's just wrong and you want a second opinion.
Mm.
AI is really, really interesting. And one of the applications that we're actually using for AI in my clinical practice, there's a tool now where it listens to the interaction that I'm having with a patient, and it will write the clinical notes for me. So instead of me having to listen and then go away and type and then listen, then go away and type, I can just fully give my attention to the patient in front of me, and that's been a game changer, and that's all because of AI. So yeah, I think it's a wonderful tool. I don't think it will fully replace doctors. Um, but in saying that, there's such a shortage of us. Like I've got to wait, and most of the people that I see in my clinic, they don't actually know that I've got a YouTube channel, and I prefer it that way. I
Mhm.
work in a semi-rural clinic that's not particularly well off in terms of the people that I see that they're not particularly wealthy, to say the least. And I think for yeah, my wait list is about 3 months to see me, which is, unacceptable. And unfortunately, that's where a lot of primary care is at the moment. There's just not enough primary care doctors to go around to see all of these people. And if we can use AI to help look after these people, in a more efficient way, I'm really, really interested in that. So it might be, one future that I can see is that if a person is trained to take a good history and do a good examination of the patient, um, maybe AI and that person then writes all of their findings into an AI tool, and then the AI can say, okay, this is probably what's going on. So here's our differential diagnosis. Here's the next steps that we need to do. And to train a person to do that might take 1 or 2 years. Whereas, to train a doctor like myself, to become a primary care doctor, I've spent 11 years training,
Mhm.
right? So if we can get these people, if we can democratize, preventative care or just care in general, by using these AI tools, I think it's wonderful. So yeah, there's a lot going on, and I just hope that the hype lives up to it because I think there's huge potential here.
Yeah, no, I agree. And it is interesting to see, like, especially depending on where you are, like, in more rural areas. Like, I have a buddy who he's actually starting a clinic in like rural North Carolina because they just don't have anybody there. And so somewhere like that, it's really needed. Whereas obviously, like in a city, you might have, whether it's a physician or a dentist or whatever, you might have one on every block. And so it's great that you're in an area that you can actually help a lot of people. But yeah, 3 months it's pretty crazy that people, if they have an issue, they have to wait quite a while.
Yeah, yeah. So we do have acute slots. So say, for example, if someone's got a cough or an ear infection or whatever,
Yeah.
there are slots in my day to fit them in. But in terms of long-term care, so we can prescribe medications for about 3 months, and then you have a follow-up sort of every 3 months or every 6 months. But again, I'm at capacity because as soon as I see a patient, they then need to book in on that day for 3 months' time. Otherwise, they won't have an appointment with me because
Yeah, sure.
that's just how full we are. So it's wild, and yeah, that's where I'm hoping AI can really speed things up and give overall better care because there just isn't enough of us, and this is where I get somewhat frustrated when there's this narrative that doctors just want to keep people sick to
Yeah,
get people
right,
hooked
right.
onto pharma drugs. There's just so many patients that we have to see, and we are so stressed out. Burnout is incredibly high in our industry. Um, and if we can find ways to keep people healthier without necessarily needing to see doctors, that's wonderful. And that's one of the big reasons why I created my YouTube channel is to try and keep people out of my clinic because there's just far too many patients to keep up with.
Yeah, no, for sure, for sure. Yeah, the whole narrative, which I think is probably a minority of people, but the narrative that it's like the doctors want us sick is it's just so skewed. Like, it's obviously both of us know many, many doctors. It's like there obviously was no point in our training or anything where it's like, all right, well, make sure you don't tell them the secrets so that they keep coming back. Like,
Yeah, yeah,
it's just
yeah.
such
It's
a
wild.
crazy notion. But yeah. Well, Brad, I very much appreciate you taking the time here. I know you're super busy. So thank you for coming on the channel. And can you tell people where they can find more of your stuff?
Yeah, I'm mostly active on YouTube, so you can find me there. I've also got a website which is drstanfield.com. But yeah, it's been a pleasure, Dave. Thanks for your time.